Hello and welcome everyone again to one of our classes in which we discuss together one of the TOG articles. We are going today to discuss placenta accreta spectrum management update. This TOG was released in October 2025, issue 4. But we have another one that was released at the same year, the very beginning of the year in January 2025, talking about imaging and diagnosis. So if you have no idea about how to diagnose a placenta accreta spectrum, you should go through this one, or you should go through the guideline itself. You can find it, it's for free. You are just going to type placenta accreta spectrum or COG, and you are going through the website. It's for free. You can download the PDF, you can view it as a web version, whatever you want. Let me show you the PDF. This, guys, is very old, but gold. So far, we are following this guideline, and the questions are based on this guideline. If you have a question from the TOG article, I'm going to tell you what would be this question. The TOG articles are the author reviews. They are authors, and this is a magazine after all. So when you have a guideline for something, follow the guideline. If there is an extra information in the TOG, okay, be aware of this extra information. Okay, you got it? You got the difference? Okay, for part 1, champions, how this can come to me in the exam. Focus on the basic knowledge. So something like this, talking about the placenta. They are going to ask you about placenta, normal one, abnormal one. How you can diagnose, or what is the pathophysiology of placenta previa or accreta. The very famous exam question, which is, if the placenta is encroaching up to the myometrium, is this previa? Is this accreta? Is this increta? Is this percreta? Very common recall. They can bring you pictures with a placenta invading up to the serosa. What is this? But they are not going to ask you about detailed management. They can ask you something like, how would you diagnose a placenta accreta spectrum? What is the best modality? From the biophysics module, for example. Is it going to be by TVS? Is it going to be by MRI, CT, PET-CT, and so on? So yeah, we depend on TVS mainly. And TVS is superior to transabdominal or transperineal approaches. So those are kind of questions that can come to part 1. And not to mention, of course, the complications like postpartum hemorrhage. It's very linked to this guideline. So in any guideline, they start with the recommendations, and then they are going to talk about each and every recommendation with evidence. Okay? For part 1, I don't need you guys to go through all the details, but be aware of numbers. And even part 2 champions, be aware of numbers. We all know that it's a very common exam question. The recurrence rate for someone who had a placenta previa before. Okay, so what is her chances to have a placenta previa or accreta in this pregnancy? This one is one of the most common recalls. You can find it here. Those are independent predictors and risk factors. Okay, we have a flashcard for it. Okay, so don't worry about it. If you need me to send it to you or share it with you, it's fine. We have collected those numbers to be neat without you going through all numbers and feeling conflicted. Question in January 2026, percentage if placenta is encroaching bladder. You mean recurrence risk or what? Incidence? Recurrence or incidence? Okay, if you remember, tell me and we can look it up together. Don't depend on me on any numbers. Definitely. I don't remember numbers. Yeah, the incidence can be found in the guideline. If not, we can find it in the TOG article. So here we are. What would be the questions for part two? For part two, of course, the same basic questions can appear to you. Whether bringing you a picture or telling you through the scenario, for example, you are having deep penetration for the villi up to the myometrium or up to the serosa. What would be that? A woman after delivery, she was having a postpartum hemorrhage and it couldn't be controlled by several measures. And after the hysterectomy, we discovered in the histopathology that the placental villi are penetrating so and so. So what is this? See? So yeah, this is the way. The other thing that can appear in your exam, I'm not going to tell you the FIGO criteria. No, this is maybe if they are going to ask it, they can ask it for part three in examiner discussion. But ultrasound manifestations, yeah, this can appear. This can appear in your exam. The ultrasound findings. Okay, so the ultrasound findings for placenta accreta spectrum is really important. Yeah, they can ask you about it, definitely. Which of the following can be ultrasound feature for placenta accreta? Or all of the following are features for placenta accreta except. This is another exam question. Can they bring me a picture like this and ask me about it? Yeah, maybe. Why not? Why not? And the scenario is going to lead you, don't worry, because the scenario, they are going to tell you that this woman is having previous cesarean sections already. They may bring you in the risk that this woman was having a niche before, or uterine dehiscence, any risk factor, and bring you this picture and tell you, what is this? Is it placenta increta, or accreta, or previa, or what? This is the placenta, and this is the bladder. They are kissing each other. So what do you think? What do you think, guys? Shall I zoom in? If you can see the placenta up to the bladder wall, what is this? Yeah, of course, percreta. Excellent. We are having a total loss of the clear zone. Total loss. We cannot see the myometrium. We even see the placenta bulging into the bladder. So yeah, all of those are ultrasound markers for the placenta. There are more and more ultrasound findings that we can discuss if we reach issue January 2025. But if we discuss it today, the session is going to be very long. So today I'm going to focus on the management update, and they were looking for only one thing. They were trying to preserve the uterus. This TOG article or the other one talking about the B-Lange or Heyman suture, our main aim is to be aware of techniques that can preserve the uterus without doing a hysterectomy, if we can. If we can. So in this management update, they are not saying anything new about the usual management of placenta accreta. It is same to same. We are going to discover it through the routine transabdominal ultrasound, the routine 20 weeks anomaly scan. We are going to discover that the placenta is not in its usual place. It is encroaching the cervix. or it is not looking normal. There are a lot of lacunae. And then when we discover this, we are going to tell our patient to come again for another ultrasound, right? This is a must. Those are the exam questions. The best next step after discovering a low-lying placenta, or you are seeing a placenta preta spectrum significance on the ultrasound, you are going to ask her to come back. By what? How many weeks? "32 weeks." Excellent. Why 32 weeks? Because before 32 weeks, I'm expecting that the placenta can migrate up. While the uterus is being bigger and bigger by time, the placenta can migrate up. So to be sure that this is a placenta previa, especially if it is anterior, I have to wait until 32 weeks. 32 weeks and beyond, the placenta is not going to migrate anymore. This is its real place. If the woman is high risk, which means that she is having a previous cesarean section and anterior placenta and previous history of placenta accreta spectrum, any of them, I'm going to do an ultrasound scan, detailed one. I'm looking for those findings, because if it's there, I'm going to refer this patient to a specialist center. This patient is going to need management by MDT. This is our patient today. Our patient today is the one who is having a placenta accreta spectrum. Okay, so if we have an opportunity, we can go through this in details. Today, we are going to see what the authors are talking about regarding the update in management. First of all, they are, as I told you, trying to preserve the uterus. So they want us to be aware of the ureteral anatomy, the bladder anatomy, and take care while we are doing the dissection, because those are the most critical organs to be injured. How we can do so? By ultrasound mapping. So we are going to have ultrasound mapping or several ultrasound pictures. And even sometimes we can go for MRIs to know where are we going, where are the depths of this placenta. Is it approaching to the bladder or invading the bladder? The urologist and urosurgeons are going to be with me also, so that they can repair the bladder if it's we are expecting a big tear in the bladder, a big injury. If we are looking for a uterine conserving management, this woman is going to be fertile again or not. By the way, part 3, guys, try to wake up with me. Mainly, your patient is going to ask you, what is my future? If I'm having a placenta accreta right now, are you going to remove my womb, or you are going to preserve it, or what? If she said, no, I don't want to remove it, she needs to be aware of the consequences. The consequences is you are going to bleed much during the operation. We are going to make our best to resuscitate you, but still, if we cannot control the bleeding at any time, do you approve to remove the uterus or not? If she said no, you have to do your best. I don't care. Do your best, but leave me the uterus. subsequent pregnancies carries elevated risk of exam question. This is exam question. And sometimes they ask you about the incidence of the risk. Number one, recurrence of placenta creta spectrum. Hemorrhage, emergency cesarean hysterectomy, preterm delivery, placental complication. Of course, this woman is already targeting future fertility, right? So this is why she is asking for conservative management. So let's see what are the predictive factors for successful preservation. Again, for 3 champions, wake up. Those are the predictive factors. Those what you are going to counsel your patient about. If she is a good candidate for uterine preservation or not. And it makes sense, actually. If you are having the feasibility for this, do you have experienced MDT for uterine preservation? So that the ability to convert to hysterectomy, if needed, it's going to be done without delaying. Do you have enough facility options? Okay, like not only a blood bank. We are talking about a facility where there is a salvage, intraoperative salvage, for example. We have experienced surgeons in urology and gynecologists, and also obstetricians who are having specific interest in placenta creta spectrum. So if you want to have a conservative surgery, we can find you that experienced team. Not only that, she is also going to play a factor. Her placenta itself. What is the extent of invasion? This is very important, right? Because the deeper, the harder to preserve the uterus without high risk complication. There is also always going to be complications. But if we are talking about a placenta invading the bladder and the lower uterine segment or the cervix, this is very bad, right? But if it's not invading the bladder and it is in the lower uterine segment only or the cervix only, yeah, this is good. We can do a dissection and we can manage it by the hemorrhage management techniques, and we can see what will happen. So it depends on the invasion. Also, the preoperative planning and imaging. As we said before, we can have a map for the placenta location and invasion extent. Vascular anatomy also is very important. If it is related to a previous scar site or not. The patient herself, how strong her desire is for future fertility. Is she anemic? Does she have any other comorbidities that can make the surgery very difficult? This is what's important. Perioperative management already is the same for any other patient, but for her, we are going to add availability of cell salvage and rapid trauma support. Those are the points that you are going to counsel your patient about. Pros and cons, risks and benefits. And if preservation is chosen, you are going to have a strategy with her. If you are going to do so, then we are going to need a plan for this. And of course, individualization. Not all patients are the same. Okay, so here we are. This is the MDT that you are going to need for this operation. This is in your mind. You are going to tell your patient or the examiner that you are going to need experts for imaging obstetrician with experience in massive obstetric hemorrhage, a gynecologist with experience in complex pelvic surgeries. This one, the one who we call it, he is the expert in dissection, an expert in dissection. The anesthesiologist should be experienced in perioperative management of someone who is going to be high risk for massive hemorrhage. Level 3 neonatal care. So I need a very good neonatologist. Access to the blood bank and a hematologist if needed. A histopathologist, definitely. Urology and vascular surgery. In addition, an experienced midwife specialized in placenta creta spectrum, a psychologist, and a physiotherapist. Those are additional. Let's see, this is the proposed algorithm. If you are going to plan a delivery with hysterectomy or without hysterectomy. I love the algorithm totally. They are telling you about the MDT and are we planning delivery or this is emergency cesarean section. If it's a cesarean emergency cesarean section, sorry, it's going to depend on mainly if this baby is preterm or not, and if there is significant hemorrhage or not. Whenever the patient is unstable, we are going to work in her best interest. But if she can consent, we are going to follow her wishes. Yeah, we are going to work fast. And yeah, we are going to consider hysterectomy. But if she told you, no, I don't want to lose my uterus because this is my first baby and I want to have other babies. Or maybe this baby is already very preterm and he's not going to survive. So I need my uterus. So we have adjuvant techniques to control the hemorrhage. Now we can go have a look over the postpartum hemorrhage guideline. What are our options? Okay, so this is one of the ladies. Another one who is stable, it's either she wants a uterine conservative surgery or a hysterectomy. Part 2 champions, you are going to be asked about this. If you have a planned delivery and you know that there is a placenta accreta spectrum, suspected placenta accreta, and the patient wants to have a uterine conservation surgery, or let's say you don't have the enough capabilities to perform a hysterectomy or to go on with this kind of surgery because you were surprised by the placenta accreta. This is exam question. Okay, we have two scenarios. One of them is, one of them you are surprised by the placenta accreta. What would you do? If you know, okay, and you are prepared, you are going to leave the placenta inside, right? What if you are not prepared and you were surprised by how the placenta is looking like, or you have tried the placental delivery and it's not coming out and the patient is going to bleed much? The placenta is really attached to the uterus. Again, you are going to leave it, deliver the baby, leave the placenta, close and transfer to the nearest facility that they can deal with it. This is the correct answer. Okay? Another thing, which they are going to talk about it in details, is to do a myometrial resection. A myometrial resection is one of the things that we can do. We are going to cut out the part that it is having the invasion and then repair the uterus. If we cannot do this, we are going to revert to hysterectomy. If there is uncontrolled bleeding or failed uterine reconstruction, we are going for the hysterectomy. They also talked about the postnatal NDT. Okay, we mentioned it. This is how it looks like. Here we are. By the way, this can appear in the exam also. Why not? Any picture can appear in the exam, guys. So what do you think here? From this Doppler, this is the bladder, okay? And this is the uterus. And as you can see, we are having, mashallah, a blood flow in the bladder wall. What is this? Yeah, we are having the placenta encroaching the bladder. Okay, forget about the TVS. Let's have a look here. This is the cervix, and wow, such lacunas and big lacunas and high vascularity toward the cervix. Okay, so here we are. This is like initial survey. You have opened up, and the uterus is looking like this. So what do you think? This is normal or abnormal? If you know the normal, you can detect the abnormal. For you guys, if you have this, tell me. No. P. Picture P. And forget about the details of the picture. If you see this is for you normal or abnormal. You see prominent vessels here? You really can see prominent vessels here? They are not that prominent. They are not that prominent. For me, I can see the bladder reflection, and I can see also that, yeah, I can see one of the vessels here, but those are not abnormal vascularities. They are showing you this because they are telling you that sometime you can see a normal looking uterus by the initial survey during the surgery, but in fact, this woman could be having a low-lying invading placenta. This placenta is not invading high. Okay, so this is typically normal. I can show you the abnormal. Is it here on or in the other one? Yeah, in the other one. Can you see the difference? Those are prominent vessels. Those are prominent new vascularities. It looks like varicosities, almost like varicosities. Can you know the difference between this picture and this picture? This one is definitely at least in Creta. This means that the placenta has reached the serosa of the uterus. But what is this? What is this? It does not look like the varicosities that we are looking for. It's like a bulging. I can see the myometrium like someone shred it up or tear it up. You know what is this? This is dehiscence. No, this is dehiscence. The placenta is bulging through a tear in the myometrium. Okay, so this one This one is what? At least increta, at least. When the placenta is encroaching up to the serosa, this is increta. If you have evidence that it invades the bladder, this is percreta. Here, I cannot see the vascularity of the placenta. This is not the color of the placenta. This is bulging, bulging. And if you feel it by your fingers, you can feel that the muscle ends here. This is soft. The muscle or the myometrium is here and here. Can you see? I don't know. Can you see it better like this? Okay, can you see that? I can feel it. Wallahi, the picture is soaking. I can feel it. This is the rim of the myometrium. So this is not placenta accreta, this is dehiscence. Why they are bringing those pictures? Because they are telling you it's not only about the vascularities or the prominent vascularities. It can be this, it can be that. Sometimes we can do intraoperative ultrasound to see what's going on. Can help us out. Someone has asked me, what would we do if we have been surprised by a placenta intraoperatively? Right? From the guideline, my dear. From the guideline. You can find here, after optimization. Okay, so this is very important exam question in part 2. I'm repeating myself. When an emergency arose and you were opening up, you have no idea that this is placenta previa or accreta spectrum. The first thing that you are going to do is to call a senior. You are going to declare an emergency and call a senior. This is number 1. Okay, so what would I do in such position? If I don't know what to do, what should I do? I hope I opened up, I delivered the baby, okay, and then I discovered that while doing placental delivery, it's not coming out. So this is a surprise, right? So there are no plans, nothing. Close and transfer. Yes. Close and transfer. After taking the baby out, okay, and you cannot do the rest, you are not good enough to do hysterectomy or to control the bleeding, you need to close and transfer. And here we are. You can do placenta left in situ, okay, and do a hysterectomy. Or if there is no enough expertise, you are going to close and transfer. Okay? Uterus preserving surgical techniques should only be attempted by surgeons working in teams. This is what the TOG article is talking about. Preserving the uterus. In the guideline, they are not talking about details of preserving the uterus. They are not going to talk about it. They are talking about real cases, okay? Usual cases. So what should we do if we have something like this? Leave the placenta inside. Either for another one to do the hysterectomy or for elective peripartum hysterectomy. So again, we can leave the placenta in situ, as I just told you here in this algorithm. We can leave it in situ when we are looking for uterine conservation surgery, or we can leave it in situ so that the patient can have elective hysterectomy later on when there is appropriate surgical team, because I cannot do it. I don't have the enough experience to do a hysterectomy, or I don't know where the placenta is invading actually. So the thing is, when the placenta is left in situ, local arrangements need to be made to ensure regular review, ultrasound examination, and access to emergency care whenever possible. You shouldn't give her methotrexate. It's going to be one of the options. The guideline is telling you, so far, we shouldn't give methotrexate adjuvant therapy. Okay? Did I answer your question? This is the one exactly, if you want to take a screenshot. The cesarean section should be delayed until appropriate staff and resources have been assembled. Adequate blood products are available. So, closure of maternal abdomen and urgent transfer to a specialist unit. Okay, if suspected accreta, which not previa, accreta, which means that I tried to deliver the placenta and it's not coming out. The placenta fails to separate with the usual measures. What should I do? Leave it in place and close and refer her. Refer her for someone who can deal with her, or for peripartum hysterectomy. Or you can leave it and do the hysterectomy. So it's according to what? Available facility, available staff who is doing this CS. Okay? If you cannot, of course, number one, we are going to call the senior. Number two, we are going to resuscitate the patient. Number three, leave it in situ. Emergency hysterectomy or peripartum hysterectomy, this is a next step to be done. But if you are ST2, ST3, you are going to do so. Okay, so back to our TOG article here. Let me talk to you about how we can do the uterine conservation. Okay, so uterine conservation in a case of placenta accreta, it means what? Control the hemorrhage. This is what we are going to do. We are going to control the hemorrhage. So again, please refer to the postpartum hemorrhage guideline. And we have also a postpartum hemorrhage quantification talk article. It's really good one, but the guideline is a must. We have a GTG, a green top guideline, and there is also a nice guideline for postpartum hemorrhage. They are the same. Go for any of them. You just need to be aware of the blood products, when to give the blood products. So again, I'm going to open it. I'm sorry, guys. There are mainly two guidelines for postpartum hemorrhage. You have the prevention and management of postpartum hemorrhage, and you have blood transfusion guideline. The blood transfusion guideline is going to teach you what to give and when, the blood products. The postpartum hemorrhage is going to give you the outlines of the steps how to control a postpartum hemorrhage. Okay? So back here. Here they are focusing on how to preserve the uterus. So today my aim was to talk to you about different incisions and how to close it and how to do the devascularization. Number one, we are going to open in a little bit upward incision than the usual one. So if you can see a myometrial defect, as I showed you before, and the dehiscence, you are going to open above this dehiscence. In general, if you suspect that you are dealing with a low-lying placenta and it's also invading, you are going to have a hysterotomy a little bit above the defect or the suspected defect. Then you are going to suture the ligating colpouterine arteries, which means that if you can see here and here, those are the places of suturing. We are trying to at least control the blood vessels that from the cervix to the uterus. And then you are going for a myometrial wedge resection. It means that you are going to take the whole problem out. The placenta with the myometrial invasion and everything. So before this, the ligation of the arteries and the devascularization is essential step, essential. Because what comes next is going to be like what you all know, the closure of the hysterotomy. Not going to be done like we are used. How should we close the CS hysterotomy, guys? In regular cases, normal cases, how should we close it? One or two layers, what type of suture, and in what technique? In two layers, continuous. Okay, continuous suturing in two layers. Okay. Excellent. With absorbable suture, mostly vicryl. Okay, a big one. Okay, size 1. Okay. Here we are not going to do this. Here we are going to use interrupted mattress pulley suture. We call it so because it's one of the strongest type of suturing ever. Mattress sutures gives you very good hemostability or hemostasis, okay? And compression at the same time. So we are going to do the mattress, but interrupted, not continuous. This is a proposed technique for uterine preservation. Again, if you have joined me right now, I'm not talking about a normal cesarean delivery. I'm talking about preserving uterus for someone who is having placenta accreta spectrum. Always the assistant is trying to compress the uterus because the assistant is trying to make the uterus contract so that the bleeding is less. Right? Okay? And you can do what's called afterwards, you can do what's called a transverse lower segment compression suture or B-Lange 2. What? What is B-Lange 2? Do you know what is B-Lange 1 or the usual B-Lange? The usual B-Lange that we use for postpartum hemorrhage control after initial measures have failed to control the hemorrhage. Yeah, it's a kind of compression suture, but it's not like this. Not like this at all. It is longitudinal one, not only a transverse one. There are very nice videos for Lange suture. In Lange suture, not sure if they mention it here or not. Do we have a picture? No. Okay. Let me show it to you. Yeah, but it's not a first line. It's not a first line. It should be done after you have already tried so many things and it's not working. Really? We don't have a picture even in the guideline? Anyway, let me show it to you. Here we are. This is the one. Up to a level, this kind of suture is technically difficult somehow. So this is why they compare it with another type of sutures, which is called Heyman suture. Yeah, okay, I remembered. It is in the other TOG article. Okay. So here, this is the beeline suture. The beeline suture is you are going to insert your needle. It's a big one, okay? And vicryl also, 3 centimeters approximately below the hysterotomy line. And then you are going to come up, okay, again from the other side of the uterus, from the other side. So you are going to insert it here and bring it out from the back of the uterus. And then the assistant is going to compress over the uterus, bring this suture, so you can here insert it again 3 centimeters above the hysterotomy. Yeah, I forgot this one. See, the Heyman is taking my mind. No, let's start all over. You are going to start where? Show me. Here. Here. And then get it from the back. And then do a transverse one. There are 8 steps. Then a transverse one. Then you are going from here to the front. Got it? No, you didn't get it. You need a video, to be honest. If I were you, I wouldn't get it. Yeah, if I were you, I wouldn't get it. Let's be honest.